Yes. And in practice, we have noticed that some patients report complete symptomatic relievement after using CMI therapy.
Yeah.
Yet their provocative left ventricular outflow tract gradient still does not reach the target range.
Right.
In such situations, should we continue dose titration to further reduce the gradient, or should symptom relief take priority in treatment decisions? Looking ahead, which parameter do you believe will be the most suitable for guiding CMI dose titration? LVOT gradient, or serum biomarkers, or patient-reported symptom and quality of life assessment, or even PVO2?
Yeah. Well, it'd be interesting to hear, everyone's opinion on this, because I think it is an area where there is some uncertainty exactly how to approach this. I'll share first my own view here, which is that, my priority is relief of symptom burden for patients. That's our treatment goal in my mind, to make patients feel like their quality of life day to day is sufficient and that they're happy with. And if they come back to me after being started on drug therapy with a CMI and they tell me, I feel good, then even if there may be in that patient some still small residual gradient, for example, I don't get more aggressive with up-titrating drug. I'm happy if the patient is happy, essentially, with how they feel. That's my goal. I think that's the goal for the patients. We can always reserve the opportunity to up-titrate the drug later if the patient develops symptoms that are recurrent in the future because of that maybe small residual gradient. But to me, the goal is patient feeling better. And if that's the case, I stop.
Yeah, as you mentioned, the next generation cardiac myosin inhibitor, aficamten, entire daily practice. And can you share with us your own experience with aficamten, and what should physicians know about it?
Well, aficamten is, the second-in-class cardiac myosin inhibitor, and it was developed to optimize, based on its pharmacology profile, efficacy, safety, and in a way, ease of use. Okay, and so it has, as a result of that, a relatively short half-life, which means it can be up-titrated relatively rapidly to give patients the clinical benefit from relief of gradient. And it can do that safely. It has a very low incidence of systolic dysfunction because it also has a wide therapeutic window, which just means that as we go up on the dose of aficamten, the ejection fraction changes are small. Okay? So we've got a wide therapeutic window, a short half-life, and what that's translated into, essentially, and this is based on also my experience now using aficamten in the real world since it's been approved in the US since December, and actually was approved first in China before the United States. But my experience in the US with it has been that, I've been very happy with the idea that when patients come to see me with symptomatic obstructive HCM, you can start aficamten. You can see them back relatively quickly, within 2 weeks, and get an echo. And for many patients, the gradient is gone. They feel good, and they don't then need to come back for another 6 months. And so you have really a very engaging, what I call patient-friendly monitoring program that reflects the favorable pharmacology, high efficacy, good safety profile of aficamten, which really makes it, in my view, a very engaging drug that makes patients balance between efficacy and safety that's excellent.
东方问道。